the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
So this dysfunction is associated with the weakness of purely pelvic floor muscles. So you can say that it results from the loss of the strength and integrity of the contractile and non-contractile tissues. So if the pelvic floor muscles are weak or if there is a sagging of pelvic floor, then it leads to a supportive dysfunction. Then if you want to see what picture is seen or what conditions do you see due to the supported dysfunction is stress incontinence. It can be a mixed incontinence or it can be a pelvic organ prolapse. That is what we normally call it as a prolapse. It can be any of the pelvic organ. Okay, so these are the basic things. If you see, you can come to a conclusion that if the patient falls into the category of the supportive dysfunction. Now, when we move to the next slide, I'll be telling you the reasons for the supportive dysfunction and what impairments do you see in such patient. Okay, so etiology goes is that the reason is the anatomic impairment of pelvic floor muscle and the nerves if they're affected in the pelvic area. This is the first reason. Second will be the vaginal delivery. Yes, then third will be the muscle atrophy due to any peripheral nervous system involvement. Then fourth will be decreased awareness. If we are not aware about this, then definitely we are going to have the pelvic floor muscle weakness. And fifth will be prolonged intra-abdominal pressure. Now what happens is that if the intra-abdominal pressure increases, then there is a stretching of the pelvic floor muscle, which leads to this particular pelvic floor dysfunction. And last and very important, which is very common right now, is the obesity. So these are the six major factors which leads to the supportive dysfunction. We have seen what do you mean by supportive dysfunction, what are the etiologies. Now we are going to see exactly what impairments do you see in the patient. Okay, then first is impaired performance and endurance of the pelvic floor. That is, the muscle is not functioning properly. Then second is that the length of the pelvic floor muscle is increased. And third is that increased connective tissue length and muscle atrophy. And fourth reason is impaired abdominal muscle performance. Then fifth is coordination of the pelvic floor muscle is decreased. That is, the contraction and relaxation ability is not going hand in hand. So that is the coordination. Then sixth is pain in pelvic floor muscle region or pelvic floor muscle. Then seventh is mobility impairment of the pelvic joint. And it is symptom of incontinence. If you see any of these impairments, then also you can say that the patient falls into the category of supportive dysfunction. Okay. Now next we'll be seeing with the hypertonic dysfunction. Now, actually the term itself gives you hypertonia, that is increase in the tone. Okay, so hypertonia is related to the pain and the spasm of the pelvic floor muscle. Now, if you want to see the conditions associated with hypertonic dysfunction, is that pelvic floor tension myalgia, then levator ani syndrome, then there is coccydynia, then vulvodynia, then there is vestibulitis, then there is vaginismus and chronic pelvic pain and dyspareunia. These are the common things which we see in the hypertonic dysfunction. Now, exactly if you see hypertonic dysfunctions, it can occur due to what? So there, if there is a pelvic joint dysfunction, then if there is a hip muscle imbalance, and if there are abdominal pelvic adhesions and scars which affect the pelvic floor function. So these are the basic reasons for the hypertonic dysfunction and the conditions which are seen in this I have mentioned above in the second point. Now we are going to move for the etiology of this hypertonic dysfunction and what impairments you are going to see. So first, we'll go with the etiology. There is a lumbopelvic joint mobility impairments or any pathologic condition which is related to the lumbar and the pelvic joint or combination of both. Then second is injuries such as fall onto the coccyx or the pubic rema. If any injury to these both structures occur, then it can lead to the hypertonic dysfunction. Then next is hip muscle imbalance with coordination, pain, altered tone, and muscle performance impairments. So this is one of the very important reason for this hypertonic dysfunction. And last is abdominal and perineal adhesions due to any of the pelvic or abdominal surgery or inflammatory condition of the abdomen. So if you see any of these causes, then you can definitely say that the person will have a hypertonic dysfunction. Okay, now what impairments you're going to see is that the pelvic floor muscle tone is altered, and along with that the other muscles which are associated with the altered tone are hip, buttock and trunk, because they have a very close association with the pelvic floor area. Then mobility impairment of the scar and connective tissue. Then there is a mobility impairment of the pelvic joints. Now here either the joints can be hypermobile or either the joints can be hypomobile. Any of these mobility impairments can be seen. So basically which joints you're going to see, because pelvic joint is a very broad term. So you can go for a SI joint, you can go for the pubic, then lumbar joint, hip and sacrococcygeal joint. So you have to go for the assessment of these particular joints. If there is any faulty posture, if there is a pain in the perineum, and if there is hypersensitivity of skin and mucosa. So these are the common impairments which we see in the this type of hypertonic dysfunction. Now we'll be moving for the third type, or you can say the next type of dysfunction is the incoordination dysfunction. So now what do you understand by incoordination dysfunction? See, there are if you see this dysfunction, there is a neurological and non-neurological conditions in which this incoordination dysfunction is seen. Now, what do you understand by that is that the detrusor sphincter dysmenorrhea is seen, and that is due to the neurological lesion in the spinal cord between the brainstem and T10. So, if you see any neurological patient with any of this pelvic floor issues, then you can put the patient under this category, that is the incoordination dysfunction. So what happens is that the pelvic floor muscle and smooth internal sphincter contract during bladder contraction, so that the urine uh, it cannot be expelled out, or there is an inability or inefficiency for the urine to be expelled. So normally, if you see any neurological patient having incontinence, then you have to find out the reasons, what condition he is suffering from, what can be the reason, and what line of treatment we have to plan. So this category of patients come in this particular dysfunction. And other is non-neurological incoordination dysfunction is characterized by absence or inappropriate patterns of timing and recruitment. Here the pelvic floor muscle function is affected. It has nothing to do with the brain, because that's why it is categorized or categorized under non-neurological dysfunction. So in neurological, the brainstem is involved, and in non-neurological, only purely the pelvic floor muscle is affected. Okay, so this is the difference between the non-neurological and neurological dysfunction in under incoordination dysfunction. Now we are going to see the etiology of incoordination. This is a purely non-neurologic etiology, because under neurologic etiology only the neurological conditions are to be mentioned. Okay, so specifically under non-neurologic etiology, you see for the decreased awareness of the pelvic floor muscles, then pain in the pelvic and abdominal area. This can also disrupt the recruitment pattern of the pelvic floor muscles. Then comes your pelvic floor muscle weakness, and then comes your coordination impairment. That is a coordination between the muscle and the function. So these are the major etiologies or reasons for the non-neurologic incoordination dysfunction. Okay. I think now we have come to the last type of dysfunction, that is a visceral dysfunction. Now, under visceral dysfunction, it is also called as a pseudo pelvic floor muscle dysfunction. Now, exactly if you want to define a visceral dysfunction, it is or you can, how to explain what are the major issues which are faced in such type of dysfunction is that it is an abnormality in mobility or motility of the abdominopelvic visceral tissue. Understand, abnormality in mobility and motility of the abdominopelvic visceral tissue that leads to the pain and musculoskeletal impairments. Okay, and the third thing is that there is a detrusor instability which is seen in the visceral dysfunction. Now, basically, if you see the etiology, actually it is very condition oriented. Means if any pathology is associated with the pelvic floor can lead to this type of dysfunction, that is a visceral dysfunction. So first etiology is endometriosis, then second, pelvic inflammatory disease. Then comes your dysmenorrhea. Then comes your surgical scar. Then I think I've mentioned the last two also in the previous slide. Sorry, in previous few slides, that is irritable bowel syndrome and interstitial cystitis. So all these conditions can lead to such kind of visceral dysfunction. Now, if you see the impairments are weakness of the abdominal muscles. This is the first thing. Then second, you're going to see the lumbopelvic joint mobility impairment and posture impairments may result. Okay. And third will be the altered tone or impaired muscle performance of the pelvic floor. And if this has occurred, if there is an altered tone or impaired muscle performance, then it can result to the pain in the lower pelvic region. So if the patient complains of the lower pelvic region pain, so you can suspect that the patient can come under this particular impairment. So as a therapist or as a doctor, we should be aware and we should be able to segregate in what category the patient is coming and what line of treatment we have to give. Okay, before we end, actually now if we consider about the treatment part, we as a physiotherapist also play a major role in treating. What happens when there is a diagnosis of the pelvic inflammatory disease, it has to be done definitely by the gynecologist. They'll give you medications. Yes, definitely that is medical line of treatment is also very important. Even they can opt for a surgical intervention. But after that, we as a physiotherapist really play a very major role that we can go for any electrical modality also can be given for the pain relief. Then the major aspect of the treatment goes with the pelvic floor muscle strengthening. So that is very important, and we as a therapist are quite well versed with the different techniques of the pelvic floor muscle strengthening. And there is a biofeedback therapy also which can be used. And one more technique that which has been well versed with this, which we rarely use, is a relaxation also can be given to the patient, so that along with the medical line of treatment or after the surgical line of treatment, if we as a physiotherapist can definitely help patient very well to get recovered from these conditions. And the thing is that we are the persons who are maximum with the patient for a longer time, as our treatment interventions are long. So definitely we also can create the awareness about these impairments, and we can also tell the patient that they should be really feel free to share what they're suffering from. And this awareness has to be created from the adolescence itself, so that the further severity and the progressions of the conditions definitely can be controlled. Okay, here we end with the session. I think it's open for the questions. Am I audible to everyone?
Yes, ma'am. I'll read the questions from the chat box for you, ma'am. So
Okay.
you and Abha ma'am can take the question.
Abha ma'am is actually not there because she's not well.
Okay. Yeah, will do, ma'am.
Just 1 second, I'm coming back.
Abha ma'am.
Yeah, just give me 1 moment. Yes.
Yeah.
You had a question?
Yes. We'll start with the question.
Yes.
As mentioned earlier, adolescents have the tendency to explore their sexuality and sexual functions. Some of them would also be introduced to the concept of masturbation. Is there any relationship between the frequency and tendency of this and prevalence of pelvic floor dysfunction in both males and females?
As such, there is no relationship between that because masturbation is considered to be completely normal. Frequency of masturbation is dependent on that person's libido, which is the sexual drive of that individual. Therefore, there is no really correlation between masturbation and pelvic floor dysfunction. However, masturbation by itself can talk to us about pelvic floor dysfunction, especially if you're looking at clitoral stimulation or penile stimulation. And if the person is experiencing pain during masturbation, either vulvar pain, vaginal pain, or clitoral pain, then they have to go and visit a gynecologist because there has to be an underlying pathology causing this pain. Most common causes for any of these pains syndromes to occur is going to be adhesion formation due to multiple reasons. It can be endometriosis, it can be vaginal adhesions, basically anything which is reducing the mobility of the tissues in this region. Another component which we do not really look at is when we're looking at clitoral stimulation, it is more of you're going to get a response into the sacral plexus, right? So if there is any underlying issue in the sacral plexus, you might face issues with clitoral stimulation. Similar, you can transfer this to the male counterpart. So any problem with penile, how do you say, arousal or penile, basically male masturbation, then they have to go and visit their doctor over here.
Thank you, ma'am. I'll put for the next question. How endometriosis can lead to hypertonic dysfunction?
Basically, endometriosis is going to be, everyone knows what endometriosis is, right? It is the inner lining, the endometrium of the uterus. So some cells are cast out and they are going to proliferate outside of the uterus, which is not their place. Okay, so it is more or less going to cause adherence between the uterus and the surrounding structures. So any of the peritoneal structures or even the pelvic floor. And therefore, it is going to lead to pain syndromes, which is going to lead to spasm of the pelvic floor, which is going to cause this hypertonic syndrome. However, endometriosis by itself is also going to lead to pelvic floor dysfunction, basically because the pain that is going to be felt can manifest in any of the regions, abdominal, back, or pelvic floor.
The next question is, could you please explain what is detrusor instability?
Whenever we are talking of the detrusor, it is supposed to be in a contracted state, okay, because it is supposed to keep the the urethra or the bladder closed, okay, so it does not allow urine flow from the bladder into the urethra. Now what happens is many a times there is a laxity of the detrusor and it does not contract appropriately, and that is what we call as detrusor instability. There can be multiple causes for that. It can be idiopathic, it can be neurological, it can be because of bladder cystitis, and therefore whatever is the cause, that underlying cause needs to be treated for us to get a proper treatment for detrusor instability. We can correct detrusor instability to some extent by giving pelvic floor contractions. However, it is a long process and it requires a synergistic movement of the pelvic floor with the detrusor. By itself, because the detrusor is not contracting properly and it is allowing leakage of urine into the urethra, by itself it is going to cause dribbling incontinence, and until and unless we target the underlying issue, we will not really be able to correct the incontinence that is being presented at this point of time.
Okay.
I'm so sorry for this voice. I'm really sorry for this voice, but it's like I'm completely congested right now.
No issues, ma'am. We can hear you properly. That's not an issue. I'll put for the next question.
Yeah.
How dysmenorrhea can be a etiology of visceral dysfunction?
Dysmenorrhea is congestive and spasmodic. By itself, when you are talking of dysmenorrhea, that's your topic actually. When we are talking of dysmenorrhea, we're looking at uterine contractions, especially when it is pushing down or it is eliminating the endometrial lining. So when we are talking of spasmodic kind of dysmenorrhea, we're looking at prostaglandin and leukotriene release from the uterine lining, which is causing a pain pattern, and therefore you can consider it under visceral.
Right. How can we assess the pelvic floor of an adolescent who is not sexually active?
Ideally, we are not supposed to do an internal examination of a pelvic floor of any individual until and unless there is consent. For children below 15, absolutely prohibited unless they are showing unless we need to have we need a urodynamic evaluation for or uroflowmetry evaluation for these children, and if it is indicated, biofeedback is indicated for them, only then can we perform the treatment component. But by itself, pelvic floor assessment for children is not allowed. It can be kind of a traumatic incident episode for them, and we need to wait for them to become a bit more aware of themselves. So for us, we need to wait for 15 onwards, and even then we really cannot go in for pelvic floor examinations till they turn 18, adults.
Right.
So for us, we have to rely on uroflowmetry, external palpation of the pelvic floor, and a lot of history, which is really difficult to get from a child because they don't know what is correct, what is appropriate, what is not appropriate, and therefore we face a lot of issues in this age group.
Right, ma'am. True that. The next question is, which electrical modalities can be used for the line of treatment?
Electrical modality for them is going to be IFT, because this is going to be treating the pelvic floor directly. You're going to get your definition of IFT is going to be holding true over here. Two medium frequency currents producing a low frequency effect in a deeper tissue. So that is the basis for us to use IFT. Other than that, you can use biofeedback which is a very good way to get that person to contract as well as relax the pelvic floor. Again, biofeedback is only indicated if uroflowmetry is showing, basically it is telling you that you need to intervene for the pelvic floor.
Okay, ma'am. Last question for today. We do have many other questions, but those will be answered in subsequent sessions and due to lack of time also. So today's last question is, young girls complain of excess white discharge and associated back pain. Is it really associated, or the back pain is due to some other musculoskeletal issues or problems?
We will need to get a history from that girl about when the discharge started, whether the back pain started with the discharge or was it a separate entity. All of us know that because we are looking at the adolescent age group, we are looking at muscle imbalances, muscle length imbalances. So your skeletal system is going to be growing faster than your muscular system. Therefore, we need to identify that first. We need to look at the child's or the individual's activity levels, how active they are, and whether that activity is also a cause for that back pain. By itself, white discharge is common because it is going to be a precursor for your menstruation, your menstrual cycle. So you are going to get some amount of discharge before and after the menstrual cycle. If there is pelvic pain associated with this discharge, cramping pain, congestion, or you will be terming it as cramping pain only, or if the person is complaining of something like that, only then will they have to go to the gynecologist and get themselves assessed for that.
Thank you so much, ma'am, for answering all the questions. I would like to thank both Rutuja ma'am and Abha ma'am for such an interesting talk. I would also take this opportunity to thank Sancheti College of Physiotherapy, our principal sir, Dr. Apurva sir, for the continuous support. And of course, our participants for inspiring us and making us aware that all these doubts and queries are still existing, and giving us a way to solve them. So that's it for today's session. I, Dr. Farheen Patel, sign off for this session today. Hope to meet you all next Saturday with the topic of PCOS, play of hormones and role of PT by Dr. Samira Hussaini, and the chairperson will be Dr. Aarti. Till then, have a good day. Goodbye.
Wish you the same, Farheen. Thanks a lot for having us.
You're most welcome, ma'am. Thank you, ma'am.
Bye.